आलमगीर भाई अस्सलाम वालेकुम।
अस्सलाम वालेकुम भाईजान। अस्सलाम वालेकुम।
फिरोज कादर अस्सलाम वालेकुम।
अस्सलाम वालेकुम सर।
वालेकुम सलाम।
স্যার আমরা স্টার্ট করি।
হ্যাঁ প্লিজ স্টার্ট করো।
স্যার আসসালামু আলাইকুম।
থ্যাংক ইউ ভেরি মাচ। আমাদের এই যে
শাহিন আমাদের টাইম 2 ঘন্টার ভিতর রাখার চেষ্টা করো। আমাদের স্পিকারদের টাইমটা লিমিট করে দিয়ে আমাদের এক্সাক্ট টাইম শেষ করে দেবো। হ্যাঁ
জি জি, আমাদের এর আগে রুহুল হক স্যার চলে যাবেন, তো একজন স্পিকারকে দেওয়ার পরে
স্যারকে দিয়ে দেবো।
স্যার বলে ঠিক আছে।
আচ্ছা ঠিক আছে।
আর আমাদের ইন্ডিয়ান ফ্যাকাল্টি ওনারা একটু ঢুকতে চাচ্ছেন, কিন্তু আমি ওদেরকে নাম্বার দিচ্ছি, ঢুকতে একটু মনে হয় কষ্ট হচ্ছে। ওনারা আসলে
আমি 7:50 পর্যন্ত থাকতে পারবো।
জি স্যার, জি স্যার। তাহলে আমরা ফার্স্ট এটা দেওয়ার পরে ওনারা এর মধ্যে আশা করে ঢুকে যাবেন স্যার। আমাদের স্পিকার তো আছে দুজনেই। আমরা স্টার্ট
করে দিই। স্পিকারদের শুরু করে দাও।
9টা শেষ আমি আবার 9টা বাজার 9:15টার দিকে ঢুকতে পারবো।
ও তাহলে তো আরো ভালো হবে স্যার। তাহলে 9:15টার দিকে আরেকটু ঢুকেন স্যার।
Yes. Good evening, Noor. Dr. Noor.
Oh, good evening, sir. Sir.
Yes.
Where are you, sir? I cannot see you, sir.
I'm online.
Yeah, sir.
I've joined. I'm listening to you. Yes, just now I'm connected. Okay, please carry on, please.
Okay, sir. Thank you,
I'm
sir.
really happy.
This our former health minister, Dr. Rulok MP sir, also here, sir. Hello, sir.
Sir. Yes.
How are you?
So you start, sir.
Yes.
So thank you very much, respected chief guest, Professor FM Ruhulok, MP, former Ministry of Health and Family Welfare, special guest Professor Konokanti Burua, Vice Chancellor, Bangabandhu Sheikh Mujib Medical University, all the dignitary faculties, speakers, and respected audience. Assalamu alaikum and good evening. Society of Surgeons already started, and we have done the 5 webinar in this COVID period. Now it is the question that how we continue our safe surgical practice in the COVID period. So in this period, for the society and for the member of the society, we have done some activities. We delivered the personal protective equipment to the all the some of the members, and we have suggested some guidelines for during this period for the surgeons who are doing the work in the COVID period. The patient now demand for surgical and procedural care in this pandemic, as the surgeons and healthcare organization have cancelled non-essential elective cases across the country before period. Now appropriate principles are necessary to guide the surgeons, nurse, local facilities in resumption of elective surgical care. One of our colleagues in this period, about 1,600 doctors in COVID positive, and about 60 doctors died in the COVID positive period. So it is one of our doctors, Mohammad Manwar. He is assistant professor of cardiology, Sorordi Medical College, died in the COVID, and before died, he gave one comment in the Facebook: a single death is a tragedy, but a million of death is a statistics. Doctors don't try to be a part of statistics, try to become safe. So now we don't lose many more of our surgical colleagues, also the doctors. So today's webinar, I am Dr. Norshen Punya Shahin, Associate Professor of Surgery, Chittagong Medical College, and Secretary General, Society of Surgeons of Bangladesh. I'd like to give thanks all the faculties to participate here. So happiness is not the absence of conflict. There is a conflict, but ability to cope with it. Now we'll go to our presentation. First presentation will be delivered by the Dr. Arif Hussain. He is the Assistant Professor of Surgery, Coxbazar Medical College. He will deliver his speech about the importance of IPC and its implementation. Dr. Arif. Now deliver the lecture by Dr. Arif Hussain.
Thank you, sir. Honorable Chairperson of this session, respected Chief Guest and the special guest and the panelists. Welcome to my short presentation about importance of IPC and its implementation. I am Dr. Muhammad Arif Hussain, Assistant Professor of Surgery, and as well as working as an IPC focal person of this hospital for 2 years. So I'm going to share my experience about the IPC. So we are in a pandemic situation by coronavirus, and in this situation, the most important thing which needs is the prevention and control. Infection prevention and controls, IPC safety measures is very much important in this pandemic situation. But the reality is we don't have any infection prevention and control program in our hospitals. So the result is the large number of doctors and health workers affected, and nearly 70 of our colleagues are died from COVID situation. So in this COVID era, we cannot do private practice or public practice without IPC. We need IPC in our government setup. We need IPC in the private hospitals, and we need IPC in our premises also. Because in this new normal situation, we cannot stop our private practice and the private and the public practice. So IPC should be in place. It should be respected, and it should be honored. So WHO, in the very beginning of this COVID situation, they released a document, and the bullet points are, they emphasized on applying standard precautions for all patients. That is, considering every patient as potentially infectious, and IPC measures for all patients. And they emphasized also in ensuring screening, triage, early recognition, and isolation of the patients and source control. Screening and triage separate the suspected patients from the hospital, and we can separate isolation units so that they cannot spread disease among the other patients, among the doctors, health workers, and also the attendants. So screening and triage is very crucial to control the spread of infection by COVID-19. They also emphasized on implementing empiric additional precautions and additional precautions like droplet precaution and contact precaution. That is the wearing of mask and the personal protective equipment. They also emphasized on the implementing administrative control. There are some role of the hospital administration like attendant control, visitor control, and the adequate doctor-patient ratio and the bed occupancy, so that we can place bed between well apart, like 3 to 6 feet distance. There are also environmental and engineering control is also important. Hospital should be good ventilation. There should be air change, cyclical air change, negative pressure room within the SDO, ICU. This should also be implemented in this COVID situation. So these are the basic elements of the standard precautions, as well as the basic components of IPC, which we should follow in every of our activities. We are concentrated, we have seen that we are concentrated only with the PPE, but PPE is not the everything which you should follow. PPE is only one component of this 8 components. So if we focus only on PPE, there are other ways to enter the infection within the healthcare workers. So hand hygiene is the most vital and the most important part of the IPC. We should follow we should frequently follow hand hygiene. We should follow respiratory hygiene and cough etiquette in the hospital. We should also need enough adequate number of PPE and inadequate quality. And we should follow the sharp management and injury prevention so that we can prevent the hepatitis B, C, and other infections. And disinfection and sterilization of the patient care equipment is also vital. We use the pressure machine, stethoscope, and patient monitor and other patient and lots of patient care equipments which should disinfect and sterilize between use. Otherwise, we can be infected from these equipments. Environmental cleaning, that is hospital disinfection, is also very vital because infected patient can keep the droplet within the environment, which should be disinfected, and we should have enough cleaners and the cleaning material to disinfect the surface. Otherwise, we can get infected from the environment. We should also implement the safe linen management. Otherwise, the bed sheet and the towels and other materials can spread infection from patient to patient. Waste management is also vital. So we should follow these 8 components in the hospital. We should practice this, but this is not individual. IPC is not individual practice. It should be institutional practice. And IPC is not a matter of short duration. We should have a long time of IPC practice so that it makes a habit of the health workers. So there are also roles from the government. This is a picture which I have taken from implementation manual of WHO. So if we want to implement the IPC in our hospitals, we should follow the 8 core components of IPC. First, we need an IPC program and specific goal, specific objective for the IPC. We need to follow a guideline. We need to educate and training our healthcare staff. We need surveillance program. We need monitoring, audit, and feedback. And there are also role of the hospital administration. They should enable the environment by management of the workload, staffing, adequate staff-patient ratio, adequate bed occupancy. We cannot handle a lot of patients beyond our bed capacity. Otherwise, we cannot implement IPC. We should have distance between the beds. Otherwise, we cannot follow IPC properly. We should build the hospital environment, adequate air change, adequate ventilation, adequate negative pressure rooms. We should have supply of adequate logistics, materials, and equipments. Otherwise, we cannot follow IPC. So this done, the guideline, education and training, surveillance, and monitoring audit. This is part of our business of the healthcare workers as well as our doctors. But this violet one, enabling environment, this is the part of the hospital administration. So we have a little experience of IPC because we started IPC program in our hospital about 2 years back, and I was the focal person of this IPC program. I am going to share our experience of Coxbazar Medical College Hospital. Our IPC program we started 2 years back, and this is our IPC team. I was the focal person from the very beginning, and there are 2 deputy focal person from the nursing staff. We allocated 22 link nurse for the IPC activity of the ward. The link nurse supervise the IPC activity. He supervised the subordinate staff and the on-job training activities. We provided 50 cleaners and 5 supervisors to supervise their cleaning activity. We formulated an IPC committee. Our superintendent was the chairperson of this committee, and I was the member secretary of this committee. We have some staff, 6 staff from the MSF Belgium. MSF Belgium supported us from the very beginning for this IPC program. 1 project medical referee who is a doctor, and 2 IPC nurse supervisor, 2 health promotion officer, and 1 Watson assistant for our wash zone. We focused on improving hand hygiene practices, respiratory hygiene and cough etiquette, improving environmental cleaning, building of a wash zone, and implemented the waste management. And we built a laundry. We have health promotion activities for the patients' caregivers, and the staffs. For implementing hand hygiene practices, MSF Belgium supplied us the hand sanitizer, that is alcohol hand rub. We have enough hand washing facilities before. We established hand washing stations in each and every corner of the world. And we supplied the basic hand hygiene requirements like liquid soap and the disposable hand towels. And we trained our staff, every staff, about the hand hygiene indication and hand hygiene techniques. These are the hand hygiene indications which you should follow in every patient when we handle patient. We follow respiratory hygiene practices in our hospitals. And we have PPE, but it is not adequate in number, and quality is also questionable. PPE is not generalized. I have to say PPE is not generalized. It is according to the risk of exposure. Ideally, it should be usable. And we trained our healthcare worker about the donning and doffing of the PPE. We arranged donning and doffing area in our isolation ward. And we emphasized on improving environmental cleaning. We trained the MLSs and cleaners, and we supplied them cleaning trolleys and materials. We have GlowCheck UV light for the training and monitoring of the training activity. We developed some checklist so that our cleaner supervisors frequently 2-hourly visit and they fill up the checklist so that everything is going okay. We have supply of the disinfectants. We use the chlorine solution. We make chlorine solution by bleaching powder. In daily and in every ward, we supply the disinfectant solution to disinfect the environment and the other patient care equipment. We have the waste management. We built a waste zone. We have incinerator for the incineration of the infected waste, and we supplied color-coded paddle bins and containers. We provided training of our staffs, and we have a close segregation follow-up. This is our waste zone. We placed incinerator, and there are different pits for the waste management. We provided color-coded bins, yellow for the infectious, black for the ordinary, blue for the glass vials, sharp. We have the sharp container, and we have the red or organic red bin for the organic waste. These are the infectious waste in yellow bin, and the ordinary waste in the black bin, and the glass vials in the blue, and the red for the sharp. And we constitute a laundry and 3 washing machine. We started with 3 washing machines in the dryer. We have 5 staff and 1 supervisor for this corner. We process linen from the general OT, labor OT, and emergency department, and also from the isolation ward. And there is a collection distribution system. This is our laundry. These are the washing machine and dryer, and these are the boxes. And we have the health promotion activity. Daily, we arrange daily session in the wards with the patients caregivers. Several topics, including the IPC, hand hygiene, respiratory hygiene, and we cover other topics. There are some video sessions, and they collaborate with our health educator. We started surveillance program, a surgical site infection after appendicectomy from 1st January of 2020. So 6 months we collected data, and we can compare 6 months after 6 months, so that if there is improvement, we can see any improvement. So our IPC team, how we work? We arrange training in groups, and there is on-the-job training in the wards by the IPC listeners. After the COVID period, as a focal person, I arranged several trainings for doctors, nurses, and the healthcare workers. So yesterday, I calculated, I provided training about 124 doctors, 90 nurses, and 181 healthcare workers, and 60 volunteers. So the total number was 465. And we have the surveillance program we make audit and we give feedback to the wards so that there would be a healthy competition between the wards for improvement. We arrange meeting in every month, IPC committee meeting in every month, and the another meeting with nurses and the in-charge nurses in every month. So identify problem in the meeting and find solution. If we cannot find solution in the link nurse meeting, then we can report the problem to the IPC committee and we solve it in the IPC committee. So this is my short presentation. Thank you very much. Thank you for patient hearing.
Thank you, Dr. Arif Hussain, in the time-demanding presentation. I think this is now about 7:30 or 35. I request to Professor Rulok sir. I request Professor FM Rulok MP, our chief guest, due to sir have another program at 7:50. So former Ministry of Health and Family Welfare, I request sir please deliver about the safe surgical procedure and deliver about the surgical society.
Thank you, SOSB, for inviting me. I hope to learn a lot. I mean, before I say something, I have a question to the presenter. How many hospitals like that IPC has been implemented in? How many hospitals? Do you know?
Sir, please.
Like what you are doing? তুমি যেভাবে implement
Yes,
করছো,
sir.
তোদের এরকম আমাদের দেশে কয়টা হাসপাতালে implementation আছে এরকম program?
স্যার সো ফার আই নো আমাদের হসপিটালে, জি স্যার বুঝতে পেরেছি স্যার। স্যার আমি যতটুকু জানি স্যার কোনো গভর্নমেন্ট হসপিটালে আইপিসি প্রোগ্রাম নাই। আমরা এটা স্টার্ট করেছিলাম স্যার 2 বছর আগে। আর প্রাইভেট হসপিটালের মধ্যে আমার যতদূর জানা আছে স্যার এই এভার কেয়ার হসপিটালে আছে এবং ইম্পেরিয়াল হসপিটালে আছে এবং স্কয়ার হসপিটালে আছে।
That's okay. Thank you very much. Thank you.
Thank you.
Dr. Arif, very good presentation about IPC. In the days of COVID, it has become so apparent that this is the important issue that the hospitals has to implement. I'd like to welcome our guests from abroad. I don't know all of them, but I would like to thank them for taking part in this session. Unfortunately, I'll have to leave for half an hour, 45 minutes, which I will be missing this important session. You see, the COVID has shown us already that infection control is the most important issue of the century, and this is what we are facing all over the world. And if we could implement what you have saying in your hospital, to most of our hospitals, the things would improve a lot. First of all, the building code, the building of the hospital itself. I do not know how many hospital architects and engineers are aware of the programs of IPC. How many of them do know that what to do? Because I can tell you my experience while I was trying to establish the bone marrow transplant unit or stem cell unit in Dhaka Medical College. During my time, we had to infuse the negative pressure or positive pressure units into the system. And when I talked to the architects, they had no idea, or they had idea, but they did not know what to do. So I had to send them to America with the to the hospitals to train them. You see, so that is first of all, I think, is the most important issue, that to train our hospital architects and engineers to build this thing inbuilt into our hospital construction system. So the infection control program has to be looked into very seriously. And what I would think from my experience, that most of our hospitals are not built in this way. We were talking about negative pressure ventilation, or in most of the intensive care units or special care units. I doubt whether there is one or two in the whole country. I'm talking about the government sector, not the private one. Excuse me. So the hospital construction and the team has to learn first. And about the program of IPC, what you are saying, I think you told me the Belgium is sort of helping us in this program. Whoever does help us, even if nobody helps us, I think we'll have to learn this. Sorry. So this is a very important program. The RFP program in our hospitals is not built in because most of our hospitals are not totally closed, which may be a good thing because I think the way I think that total closure or central air conditioning probably not as good as the open air ventilation system. So that has to be thought of and has to be taken into consideration. Our waste management, land management, and cleanliness and cleaning supervisors, what you have said, if they would function and they would work what you have said in the way that you have mentioned, I think we will have minimum problem. COVID has showed us that infection control is the system. The way our doctors are leaving us, almost about, I think, about 60 plus or plus, near about 60 doctors have died in Bangladesh. And many health workers are infected. So it is not only, as you said, the PPE, donning and doffing, but many other factors are involved to prevent the infection to the health personnel. And this is to be taken very seriously. We have very senior teachers here, especially Surgical Society. I would say Professor Konok, especially he is the Vice Chancellor of our university, and that university shows us the way. So our also very senior teachers are there. Professor Majid, a retired professor who is a good friend of ours, is also here. So also are many other senior teachers. I think this has to be practiced, first of all, to be learned by the seniors and the juniors, and to practice the IPC control in the hospital. So to bring this into the system, I think it will take some time. I believe the junior doctors, the junior youth people, what you are saying has to be taken to very seriously. I feel what you quoted somebody saying that when somebody goes, when a doctor dies, it's a real sad situation. All of us come from a very middle class background, and we know if the person, a doctor dies, what happens to the whole family. So we don't want to become a statistic. So that is what I really believe. I have been talking to many of my friends and seniors and health managers of the country that there is some problem in our management. That is the reason why the doctors and health workers are getting infected. And I was proposing yesterday in another talk show that we must have a commission to look into what is really happening. Where is the problem? Why is it the PPE, or is it just wearing it and taking it off, or is there so many other factors in between that we are missing out? So I would request my senior teachers here, as I am just an offshoot and see from outside. So I am not taking part in any real management. It's your duty that please do look into this very seriously. Why and how and where are we missing the link? If we cannot prevent this, we'll lose a lot of health workers, especially doctors. So please, this is a very important information that the IPC that we are discussing. Also, the surgical practice that we will be possibly discussing later. If I come back later, I hope that I will be able to hear it and know it from you. How to do surgery in emergency cases, in routine cases, and how to prevent the infection in the operation theater. These are very important issues. I believe some of our foreign guests are here. they might bring it out and to discuss. I won't take much time. I would like to listen to some of the things before I leave. So I wish you all the best, and let's take care and learn and try to manage the infection control to prevent COVID. We are all with you. I am with you and wish you all the best. Thank you. And I'll be here till another 10-15 minutes and before I leave, and then I'll come back again. Thank you very much. Thank you.
Thank you,
sir.
sir.
Thank you, sir.
Thank you, Professor. From rule of MP, former successful health minister, Ministry of Health and Family Welfare, for sir elaborating about the IPC control and the whole of the surgical faculty. Now I would like to request Dr. Ashbin Bawa. He is Associate Professor of Surgery, Dayanand Medical College and Hospital, Ludhiana, Punjab, India. He talked about the safe protective gears and their reuse. Dr. Ashbin Bawa.
Hello.
Yeah, hello. Yeah. Yes, yes.
Can you see my slides, please?
Yes, we have seen your slide.
Good evening, everyone. It is a proud privilege to speak on safe protective gear and their reuse. I'm Ashwin Bawa, an associate professor of surgery from DMC Ludhiana. It's a 1600 bedded hospital. First of all, I'd like to thank the Society of Surgeons of Bangladesh to have given me the opportunity to come and speak on this very, very fairly important topic. I would personally like to thank Professor Abdullah Al Mamoon and Professor Muhammad Noor Hussain Shaheen for coordinating and getting this organized. So this is my hospital. This is a 1600 bedded hospital in Punjab, India. So first of all, my disclosures. I am a general surgeon. I am not a microbiologist or an infectious disease specialist. And I'm trying my best to dodge COVID-19. We know that it's a viral disease and perhaps it will prevail somehow. But as a surgeon who has to protect his patients, his families, we can just try our best to dodge COVID-19. And personal protective equipment is one of the best ways to do so. So highlights of the presentation, I'll be speaking on certain PPEs, what constitutes PPEs, and reuse of PPEs in these COVID times. We all are using them again and again, and certain tips and tricks which are useful for preserving and using PPEs. So this is a slide from Occupational Safety and Health Administration USA, which talks about the ways to eliminate a crisis situation. First is engineering controls to eliminate a hazard or isolate workers. We cannot do this because we have to go to our work. Second is administrative and work practice protocols, for example, limiting the number of patients that come and social distancing in hospitals and other things. The least effective of these all is personal protective equipment, because as healthcare warriors, we have to face the patients, and these protective equipment just makes us face the virus and protect us as the last resort. We are not curtailing COVID-19 in any ways. We are just protecting ourselves. That's it. So this is what is the problem with COVID-19. We know that the virus can spread through heavy droplets, which can cause infection in asymptomatic, uninfected people. Then there is aerosol transmission, which is now known, and the third route is contact transmission by contaminated surfaces. So to prevent droplet infection, we have surgical masks or face shields which prevent these large droplets with virus loads to reach us. The aerosol transmission, to prevent aerosol transmission, you would need N95 masks and full face shields and coveralls to prevent the aerosols to reach you. For contact transmission, we have our hand sanitizer and cleaning of surfaces that we frequently do. So for somebody who's visiting the hospital or going to the hospital on a daily basis, according to the WHO, they say that when you enter an area where there is no patient contact in a hospital, you would just need a surgical mask. For areas where there is direct contact with COVID patients, you would need a surgical mask, gloves, a disposable or a reusable surgical gown, and an eye protection and face protection. And N95 classically is not required for if you are just in a vicinity of a COVID patient. I will give my version also in some time. For aerosol generating procedures, everything remains same, and an N95 is required, which properly seals your face. If you are cleaning a COVID area, again, they say that an N95 is not required. For a lab technician who's drawing samples, an N95 is not required. But the important point here is that most of the patients that are reaching us are asymptomatic carriers who would not even know that they have COVID. So, for example, if you have, I've been to Bangladesh as faculty before. I know that it is like us, very crowded and lots of patients coming in. A medical doctor or a healthcare worker needs to take as much protection that is available as possible to prevent infection. And I think if you're seeing about 30, 40 patients or a lot of patients in a crowded environment, an N95 will offer a good amount of protection because classically all our offices are low roofed and with a lot of patients not following proper mask wearing etiquettes and everything. We need to cover ourselves properly to avoid infections. Face shields per se are very, very important because contact transmission by eyes is known. We know that the common routes are mouth and nose, but the spread through eyes is also known to occur. So please keep protecting your eyes. I would suggest that as much as possible, use an N95 so that you breathe through an N95 and filter most of the air that you breathe in the hospital, which is important. So there is certain evidence for the use of all these equipment. This is from Cochrane review published in 2011, which speaks of all these things: frequent hand washing, wearing a mask, wearing an N95 mask, wearing gloves, eye protection, and even cleaning the nose, as these all protect the odds ratio of getting the virus. This was for respiratory syncytial virus. So these show that all these are significant protectors for getting an infection. So this is a very colorful slide I tried to make for this particular presentation, which shows most of the PPE that is required except the coverall suit. We need to have a head covered with a scrub cap or a disposable cap. I prefer using a scrub cap most of the time because it is washable. You can see goggles here, which provide full eye protection. I also wear prescription glasses. Such a glass would give you good eye protection from all around and will seal your eye areas. An N95 mask we'll be talking about in detail. This is a disposable gown. Definitely gloves, nitrile gloves, latex gloves, whatever gloves you find will give you adequate protection. On the left-hand side, you would see, you would come to the minimum that would be required in case we do not use disposable gowns. Please definitely wear an apron. If gloves are in short supply, please use in non-COVID areas, use adequate amount of hand washing. 3-ply mask is again, I will be talking in detail about what a standard 3-ply mask looks like. A face shield is totally important in this corona war and should be used at all possible times in the hospital. So coming to the first thing in personal protective equipment, the basic is a mask, and the masks which cover our face can be of 4 types. One is the simple surgical mask that we all surgeons have been using at all times. We know that a surgical mask would only protect our secretions from falling into a patient while we are operating. The filtration capacity of a surgical mask is about 80 to 90%, but a normal surgical mask does not seal our face. So we tend to breathe in from the sides and it does not provide us adequate protection. The second is respirators. This is the hottest topic everywhere, the N95. So a standard N95 should cover your face, seal your face properly so that you do not breathe from the sides. I would emphasize sealing your face again and again because this is the most important thing that can protect any healthcare worker from infection. If you are breathing from from the sides of an N95 mask. These masks are apparently useless, and it's like nothing, wearing nothing at all. On the third left is the elastomeric respirators. I have a lot of things to show you as well. These seal your face very well, and the amount of protection they offer is about almost to the power of 100%. I have both the full face shield and the half mask available for you to show. On the right hand side is the powered air purifying respirators. This is the ultimate protection that a healthcare worker and a surgeon can get, and it is apparently more useful for aerosol generating procedures since it has HEPA filters which filter about 99% of air reaching inside. So coming to surgical masks, always remember, we tend to forget. I notice a lot of patients who come to us wearing surgical masks which look dirty and old. The lifespan of a surgical mask is only 6 hours. The front of the mask is pretty dirty. As surgeons, we sometimes tend to forget these basic things. We need to remove the mask from the sides and dispose it off. Do not use it for more than 6 hours. Please guide all your colleagues as well. It has 3 layers. I never knew that it had 3 layers. Once you get into this safety equipment for COVID, you learn all these things. I cut open a 3-layered mask and actually saw the 3 layers. The layer inside is the melt-blown filter. Please do not reuse your surgical masks. So this is a diagram showing anatomy of a 3-ply mask. The outer layer is hydrophilic, which does not let droplets. If particles are coming from front, the particles cannot penetrate through. The middle layer is the melt-blown filter, which has electrostatic charges and does not allow particles to pass through. The inner layer is the absorbent layer, which helps the patient or the surgeon's secretions to get absorbed. So the most effective masks have a nose piece that fits in. That's for tightly fitting, snugly fitting of the mask. Virus particles can leak out from the sides and gaps of the from these masks. Masks should cover the chin. If you notice, most of the patients, in fact, coming to us here also have either their mask down or their masks are usually pointing upwards. These masks are useless. Please keep educating your patients. As surgeons, as physicians, our responsibility is to keep educating and keep telling your patients to follow proper precautions. This will prevent further infection into healthcare workers. The more we spread the word, the better it would get. So this is meant for general public and for patients and even for healthcare workers. We need to fix the surgical mask properly from the nose so that it fits in. I forgot to touch. I'm touching my face again and again, but you need to sanitize your hands before you do that. Pull the mask from the below the chin as well. Do not touch the front of your face or the mask. Do not pull the mask down. Once you have to take off the mask, take it off from the sides. Dispose it off. We use the yellow bins for discarding these masks. I do not advocate reuse of surgical masks at all. So coming to the second point, we have the respirators. These are ideally meant, are supposed to be single use and are meant for basically the N95s came up for other occupationals like for working in coal mines or when you're working in saw. For example, you have fires in Australia where they use them for fumes and other things. Their use in healthcare came up for tuberculosis in 1994 and on and off has been used in Ebola and for influenza and other pandemics. These reduce particles from coming in. There is a melt-blown layer in this as well, which is thicker than the surgical mask, which according to the principles of electrostatic energy, do not let larger particles to go through. Mask fit is the most crucial steps. If there are gaps from the side of an N95 mask, it is almost useless. Facial hair, you have to keep yourself shaved all the time if you have to wear an N95 mask. So what does an N95 signify? N signifies it is non-oil resistant. If you have some of these, this is a P100. P100 means that it is oil proof. N95 signifies that 95% of particles that pass up to the size of 0.3 micrometer are filtered through this. 100 means that almost 99.97 particles passing through this are filtered through it. But please remember the size of the COVID virus, coronavirus is even smaller than them. But what happens is that since they are very, very thick and there are multiple layers of melt-blown filter, I don't know if you can see this, these fibers inside which, filter, and with this electrostatic energy, these particles get stuck up in these filters and filter most of the particles passing through. So what happens is, what is an N95? How do you identify the correct N95? The best N95s are NIOSH certified. You will find some masks, I don't know if they're available in Bangladesh or not. So here is N95 written. This is an N95 mask. You can see N95. This has got NIOSH written on them. In fact, we have another Indian manufactured mask which says NIOSH written. This is NIOSH stands for National Institute of Occupational Safety and Health, which is a US agency which standardizes the masks that are supposed to be used. And the best fit testing masks are the NIOSH certified ones. I am lucky that I have supply of some of these for myself and my family. These seal your face pretty well from all sides and do not let air leak from the side. The other options, this is from 3M, this slide, most of the pictures and this table is from 3M, which says that there are certain equivalents to an NIOSH mask, N95 mask. These are, if you see, I don't know if they're available in Bangladesh or not, these are the KN95s. KN is the Chinese standard for an N95 mask. The problem with these masks is that once you wear them, the air still leaks from the side and they do not fit me well, probably because they are made for the Chinese morphology of the face. So what I usually recommend is you tape this from the side to fit you well. Always remember that if your N95 is leaking air from the sides, it is deemed useless. The other ones which are available are the FFP2. FFP2 is the European standard for an N95 mask. On the slide on the right-hand side, on the lower edge, you can see that they filter about 94% of the particles. FFP3 masks filter about 99%. I haven't seen any FFP3 mask in India as of now. Please remember, this is a very busy slide. These masks are not to be used. This is a mask by 3M, and this has FFP1 written on them. FFP1 filters only 80%. Please do not feel secure in these masks because they filter about 80% of the particles passing through them. This is another, I'll be speaking on the valve mask in the next few slides. This is another of these, I hope I'm clear, shows FFP1S. If your mask says FFP1S, please do not use them because they filter only 80%, not an N95, which filters about 100%. There are other types, the P2 mask, which is the Japanese equivalent to an N95. So please remember these important points about the N95, how to correctly identify the right N95 mask for yourself. So what happens? Coronavirus can survive for hours on surfaces like fabrics and gloves. So PPE can be an additional mode of infection transmission. So donning, doffing, handling these masks properly is very, very important because we might contaminate ourselves and we would not even know. Maybe we have to follow all possible precautions. This is a basic anatomy of an N95 mask. The outer layer is made of supportive materials, maybe polypropylene and other things which add support. And the inner layer is the basic melt-blown filter, which filters most of the particles coming through it. The basic science of an N95 is, again and again, I speak of the same thing, is sealing of the face. It should seal the face and everything should filter through the N95's fibers, which on the basis of electrostatic energy filter most of the things passing through it. So I got this, this is, if you Google for the astounding physics of an N95 mask, the slide was taken from Minute Physics, which shows that particles, large particles are blocked 100% when they pass through the layers of an N95 mask. Even for dust and everything, they block about 100% particles that pass through it. So the other tiny ones are blocked 95%. They would get stuck in the fibers of an N95, and hardly any fiber can finally reach inside an N95. So coming to the next part, these are elastomeric respirators. On the left-hand side is the full face mask, and on the other side is the half face mask. Both have pink colored filters. These are actually called P100 filters. They filter about 100% and are totally resistant to oil. Also, I personally do not like the one on the left because the full face shield, once you wear in a surgical setting with the AC not on these days, so what happens is a lot of sweating happens, and one cannot see, and it is very uncomfortable. On the other hand, the half face mask is better if you get it. These are the filters which are supposed to be used. These are the P100. All of them have NIOSH written on them, which means that they've been certified by the National Institute of Occupational Safety and Health USA, and provide 100% protection for most of the particles. So for elastomeric respirators, also a fit test needs to be performed every time. P100 can be used till breathing becomes difficult. So technically, up till 30 uses or up to 3 months, you can use them. You have to clean all surfaces of these respirators after use with alcohol. You can just disconnect it and immerse it in a detergent solution and leave it to dry. Respirators need to be stored in sealed plastic bags after drying so that they don't catch any fungus or mold. This is a PAPR. This is the PowerL Purifying respirator, which has a HEPA filter. You can have the HEPA filter at the back of the head. I have the unit here for display purposes. The other PAPR is by 3M, where the unit, the HEPA filter is placed on a surgeon's back. I personally find the one on the left more useful because everything is in the head and part of the helmet itself. You require special isopropyl alcohol 99% to keep this respirator really clean, and you have to be very careful while doffing this since you can self-infect yourself while removing it. A special word for valved respirator masks. I put in a big video and made this video especially for you guys. These valve masks allow unfiltered air to come out of the mask. Please remember, any patient coming to you who may be an asymptomatic carrier in your office, breathing out through this valve mask might be leaving particles everywhere. In fact, even if you're wearing a mask, the particles can stay on surfaces for up to 72 hours or even 5 days and infect other surroundings. In fact, if your colleagues are also wearing it, it is not good to contaminate the surroundings. So please be wary and totally avoid these valve masks because they're allowing unfiltered air, maybe laden with virus particles, to go out. It provides good amount of protection for the wearer and are very easy because they find them very easy to breathe out from the expiratory valve. But most likely, you are contaminating your surroundings. I saw somebody in one of the Facebook posts, one of the surgeons in Bangladesh, wear this. I especially put a message. These have to be totally avoided. It is very difficult to convince the public here as well. I'm finding it difficult. I wrote to the PM as well, but I think so valve masks have to be fully avoided. Coming to the next part of it, why talk of reuse? The truth is that, in fact, even for us, we have stuff in limited supply. I personally have been using my N95s on a daily basis with adequate amount of care. Secondly, some of these are selling at very high premium prices. There's black involved in getting these genuine ones, so they're turning out to be very costly. So making it cost effective is very, very crucial, and so that's why we are reusing most of our stuff carefully. So what things you need to consider while reusing this mask? Do not think that dipping these in soap water or alcohol or bleach is useful. They will spoil the respirator totally. You will not be able to use this. The filtration mechanism would be rendered useless. Even microwave heat and high dry heat, for example, autoclaving can cause degradation of the fibers. I have special interest in UV sterilization. In fact, I would show what I did for UV sterilization. Low dry heat is found to be useful, even vaporized hydrogen peroxide, but I don't personally have experience with using vaporized hydrogen peroxide. So secondly, most of us, what we are doing, and most of what my colleagues are doing is not using the respirator for 5 to 5 days. What it does, it kills most of the viruses, and we tend to leave it in brown packages so that most of this decontamination occurs on its own. I made UV just because I was not fully happy with this amount of sterilization. So what is effective decontamination of an N95 mask? Anything which decontaminates this mask should preserve its N95 filtration. Secondly, the fit of the mask should not get spoiled. We should not spoil the mask. It should still fit the way it used to be in the first go. It should kill all possible organisms, especially viruses. And for example, I read about ETO sterilization of masks. It releases some chemical which may be harmful and cause maybe carcinogenic for the face. So these masks are not supposed to be, you should not adding additional residue to the mask. So what is an ideal mask that you use for decontamination? It should not be soiled, for example, with the ladies' makeup or anything that you've eaten. The nose piece should be intact. The straps should be intact. The straps should not fall off. In fact, the 3M mask easily breaks from the straps. There should not be any tears on the surface. No sort of deformation of the masks. Discard all masks that are soiled with broken straps, with nose piece displacement, with fracture of the nose piece, with tearing of the N95 respirator or deformation. This is the protocol that I like and follow. You can see my masks in envelopes labeled according to days and numbered with my name written on it so that they do not get mixed up with anyone. You have to perform hand hygiene before donning, and sorry for a busy slide, but before donning an N95 respirator. Inspect the N95 respirator for any evidence of physical damage. This is the matter of our life. We should not risk this at all. We should not be casual in holding this. I'm being very casual by holding it from this, but ideally should be held from the straps itself. Always perform the fit test. I would not do it right now, but how do you check for the fit test is to be performed by the institutes. I'm sorry here. You have to perform the air seal test. You wear the N95 respirator and hold it from the edges and try to blow expire air out, and air should not leak from the side. Similarly, try to inhale through an N95 respirator. The air should not enter from the sides. Always try to protect your N95. That means you either cover it with a surgical mask or a face shield. What this does is it spoils the surface from getting the external surface from getting contaminated. The face shield on one hand provides coverage of our eyes, also protect the N95 from getting dirty. Perform hand hygiene after doffing. Doff mask into a clean paper bag with date and name. Handle only with straps. Store bag in proper storage place in a cool environment, away from other things, and it should not be over things, and it should not be in your locker. Surgeons have dirty lockers and there are lots of stuff lying, so please do not place it in your almirah. Set at least aside for at least 3 or up to 7 days. As much as you leave it like that, it would be better for this. Before donning a used N95 respirator, again, inspect the surface for any damage. Wear gloves to don a used N95 respirator and perform hand hygiene after that. So do not handle this. Consider this still to be slightly dirty and do not use it directly. The maximum recommended days of N95 respirator reuse is 5 days. So, but what I do is usually I take these 5 packets and use it for 4 days. and these packets last for about 20 days, and I then get a new set and use my other N95 masks. So what I did was I was not really convinced with cleaning these face shields and other things and these masks with just not like that. It's a surgeon's belief that you should keep trying something new. So what I did was I had an old phototherapy unit lying in the hospital somewhere. I replaced the tube lights inside that with UVC, with Philips UVC lights, and I upscaled it to 4 15-watt UVC lights. So this is more effective than other things, and I exposed them at a shorter distance. I put in reflective foil paper inside to make it almost shadowless. I have certain papers coming up on this. I've already been able to decontaminate most of the things that are placed and been validated using these Petri dishes of gram-positive, gram-negative, and even fungi. So the key considerations about UVC are that there is a certain amount of dosage of UVC that is required to decontaminate the mask. Ensure that accurate UVC dose is given on all surfaces. If your mask is something like a cup, you have to expose both surfaces to UVC for some time. My UVC sterilizer, the times of decontamination are coming out to be less because we have upscaled it to about 60 watt. I do not know whether it is causing any loss in integrity of the N95 respirator mask. The things to be careful about UVC are that it is very harmful to eyes and skin, and all those products which expose UV light. For example, you might see there are wands available in the market, should not be used at all. Other things which are not to be used or whatnot are that sunlight is not a replacement for UVC. These consumer products which are advertised, for example, those mobile boxes, are not adequate UVC decontamination methods. Anything less than 200 nanometers, the exact UVC dose has to be in this spectrum of and exactly has to be 254 nanometer. Rest is biosafety cabinets that might be available in the microbiology department do not give adequate surface sterilization of UVC. The unproven methods are autoclave gives about 110 steam at 121 degrees C. This would disintegrate most of mask surfaces and should not be used. The ideal heat that is good is about 70 to 80 degrees C for about 15 to 20 minutes, for about 50 minutes. Microwaves should not be used, and your home ovens should not be tried. Do not take your dirty masks home at all. Hydrogen peroxide, I personally have no experience, but it is considered to be good. But the only problem with hydrogen peroxide is longer decontamination times. We are not using hydrogen peroxide vapors in a hospital for decontamination. The other safety gear that I wish to talk about is face shields. It is one of my favorite topics. I cross so many colleagues in my hospital and tell everyone to wear a face shield at all possible times. A face shield is always better than eye goggles unless you are in an isolation ward where both should be worn together. Remember, anyone who says that your prescription glasses give you adequate coverage, it's absolutely not good. You need to have a face shield to cover your N95 masks. Benefit of face shields, I could not exactly get the quote from where this paper is from. I'm sorry that, but it says that face shields cause reduction in contamination of mask to the tune of 76 to 97%. They reduce aerosol exposure. There is threefold low risk of SARS with face shields. It avoids, if you're wearing a face shield, you would not touch your face and again. And face shields are cheap. I get mine for about 35 rupees, and it is very easier to clean. You can keep using your face shields for as long as your vision is not lost. So even hand sanitizer and even hypochlorite is good enough to clean this. I use UVC again to clean the surfaces. So now coming to another interesting thing, there is coveralls. Coveralls are supposed to be used in isolations. I've tried using them in ORs. The coveralls, you should be careful of using the taped ones because they prevent total leaking from the sides. We have washable ones available here for non-COVID areas. Otherwise, proper coveralls should be single use only. Then for OPD purposes and for ward rounds, you could use your normal surgical gowns, which can be washed, but be careful of removing them very, very carefully. So these are certain pictures. I've been using this coverall with a face shield and N95 in OT while doing laparoscopy. Others is I was doing a proctological procedure while using this half mask, and you can see everyone in the OT is wearing a face shield with an N95 and covering them with a 3-ply mask. Even I am covering the valve of this respirator with a 3-ply mask to prevent my droplets from falling into the patient or contaminating the field or contaminating or infecting my colleagues. One of my pictures went viral, which showed the basic COVID essentials to be used in these times. You can see face shield. I keep on using my Bluetooth so that I avoid touching my phone again and again. My N95 is covered with a 3-ply with a face shield. Scrubs, it is better to wear in the other areas of the hospital, but for patient contact, wear a disposable gown. Nitrile gloves have become a part of our life. The thing about them is that you can use them up to 20 to 30 times by frequent washing over the nitrile gloves till you, but for every patient contact, you can use them again and again. Here I'm also using a mobile waterproof case to prevent my mobile from getting contaminated. Be careful of your mobiles because they're almost a petri dish these days. My interest in masks and other personal protective equipment made my son draw these drawings. I was pretty surprised. He also knows that an N95 filters in air in the first picture. So he says, avoid dust masks, which are FFP1. Please see those numbers on your masks. If you cut open a 3-ply mask, you'll be able to see 3 layers. Valve mask, he says, is dangerous. Cover your KN95s with tape so that no air escapes from all sides. Look for NIOSH certifications on an N95. He described various shapes of an N95, even shown half mask and full face masks. Safety isn't expensive. It is priceless. Please do your best in whatever we have. I'm open for any discussions and questions.
Thank you. Thank you, Ashwin Bawa. A really excellent presentation. You covered all of the side of the protective gears and how use and reuse, how to protect, how it decontaminate, everything. You covered all of the aspect of the protective gears. And thank you very much for
Thank
your
you, sir.
everything covered. Now,
Thank you, sir.
Before going to the question and answer, before going to the discussion with the panel, here there are so many our senior faculties here. So I would like to request any comment from the senior faculty here. From the senior faculty. Any comment from senior faculty?
I must congratulate this speaker for his very wonderful presentation. Can you hear me?
Yes, sir.
Sir, Moses, sir. Yes, sir.
Yes. I must congratulate him for his very wonderful presentation on especially issues of protective gears. I would like to know from him what is duration of the experience with all these gears.
Sir, so thank you for this question, sir. Sir, since the time, I think so in India, we started a lockdown on 23rd March. So I have been fascinated and have been using it since as long as possible, all these protective gears. So this is not before the lockdown, but since lockdown, most of these things have been used and reused over time, sir.
And what is the, sorry, can I ask another question?
Sure, sir.
And is there any evidence for or against some of the protective gears that you have described?
Sir, evidence, sir, I quoted a paper from 2011 for respiratory syncytial viruses, which is a Cochrane review. So they say that most of these things prevent getting infected. The two things which do not give you adequate protection is one is headgear, and the second is shoe covers. So there is not evidence against, but they say most of the infections occur from removing and doffing either shoe covers or your headgear. So you have to be very careful while removing these two. Others are there's a lot of evidence which COVID is a developing story. We would not be we should not talk. I let a lot of my colleagues also know that we should not talk of evidence right now. We should talk of safety. When you have 60 people dying in Bangladesh and 100 healthcare workers, doctors dying in India, I think so safety is more important than evidence. I tell it to a lot of my senior colleagues. So we should put our best in safety.
When I asked you this question, I had the question of safety in my mind.
Okay.
Evidence in favor of safety. That's what I wanted to know.
Yes.
So thank you, sir. Moses sir, any comment or query from senior Firuskada sir here also, and other faculties? Shafkat sir also here. So any question or comment, sir?
Yeah, Shaheen, can I just add a few words with what
You're the
Baba has
faculty.
said?
You're the panel, sir.
Yeah.
Okay, sir. Okay. Okay.
No, should I go right now or should wait for my turn to come later?
Just come later, sir.
Okay, thank you.
This sir.
Okay, can I talk?
Yes, sir. Yes, sir.
I congratulate the society for the wonderful program that we have taken up and the most important issues of these days, which have been taken up by Dr. Arif and Dr. Ashwin Bawa. Arif has nicely presented the infection control strategies that should be adopted in all the hospitals, especially in the teaching hospitals. And he has said, he has named a number of hospitals. In addition to that, there are some more hospitals where these type of strategies are taking place, are in existence, which are all taken by personal initiatives. There is no initiative from any authority or from any management or anything like that. As has been said in the comment session, where Professor Maudud Salambi said that in an institute in Bogra, he has an infection control strategy in his hospital where he works. So there are certain hospitals where these are carried out. So from the government point of view, these should be an essential element to have infection control strategy to get a registration for having clinical practice in an hospital. That should be made sure that these things are being carried out. And the presentation which has been given by Dr. Arvind Bawa was an excellent one. It was very extensive, very thorough. And he has pointed out the loopholes that are to be pointed out and that should be taken care of. So having said all these, the different problems, especially the fit test, the reuse of the mask, and all these things should be taken into account to reduce such a huge mortality in the healthcare workers. Thank you. This is an excellent program that is going on. We'll have further discussion. Thank you very much.
Thank you.
Thank you, sir. Now we go to the panel of experts. I would like to request Professor ABM Khurshid sir. Professor ABM Khurshid sir. Sir, here.
Yes. Sir, can you hear me?
Yes, sir. Yes, sir. Please, any comment or query about the operation theater.
Yeah, I'm going to ask some questions to the faculties as well as the participants. I would like to narrate the one events in our world. The first patient which was proved as an COVID-1, we operated on that patient as an emergency basis, and later on we came to know that the patient was affected by COVID. But surprisingly, the members were in the team, there none was affected. But the affected person was who worked in the ward and who received the patient first. And later on, when we started the dedicated COVID OT, not that like that of the negative section or negative air pressure, the dedicated COVID OT, one emergency, and recently 2 routine OT. And in one emergency OT, the first surgeon who did the surgery there with all PPE and other protection, he became infected. And after 21 days, that becomes positive. I don't know how it happened. And I would like to know regarding the pathogenesis and other things, and how it is possible that after 21 days of performing a surgery with all protection, someone gets positive and all the symptoms arrive. So in our operating theater, still now, there is no negative pressure or negative suction mechanism. We are doing the traditional operating theater, and the operations are being done in a traditional way. There is air conditioner, and sometimes they are using the fan as because the air conditioner is not working. But even then, what Asbin Bawa has shown, the mechanism of wearing the mask and the gowns and other things, we did more or less very near to him. There is something, some mistakes I found that after his demonstration. But almost I can say that 90% we are near to his demonstration. But even then, our doctors are getting infected, especially the surgeons. Quite a good number of surgeons of Dhaka Medical College right now are affected, and they become positive, and they are now abstained from the work, and we are running in scarcity of the surgeons. I don't know what will happen and how to get rid of these conditions. Thank you, Shaheen. Thank you, Society of Surgeons, for arranging such a nice webinar, as well as the foreign faculties. Especially, I'd like to thank the Asbin Bawa, and I was a bit late, so I could not go through the presentation of Arif. But the last part, what I have seen, that was a very good and very nice one. I think I should conclude at this moment with these few words. And again, I am thanking all of you. Stay safe and stay blessed.
Thank you, sir. Thank you, Professor ABM Khurshid Alam. He is the head of the Department of Surgery, Dhaka Medical College. Now, I would like to request Dr. Ramana Balasubramaniam. He is the founder trustee, AWR surgeon, laparoscopic and bariatric surgeons, Kolkata. Dr. Ramana.
Thank you.
Just
Good evening.
Good evening, sir. Thank you very much.
সবাইকে আন্তরিক শুভেচ্ছা জানাচ্ছি।
Ji, sir. Ji, sir.
I'm not an expert on COVID, but I'm a keen student, and I've been seeing dozens and dozens of papers coming up every other day, and it's too much of information, and it has the negative effect on all of us. We tend to shut the door down on all information, good, bad, ugly, everything gets shut down. So we are in danger of that. So effectively what happens is you then become underinformed. So it is good to have some concise program like this, where you get distilled knowledge, and you basically know that, okay, this is the main substance and all the rest is fluff. Now, in terms of COVID prevention, which is essentially why every surgeon is listening on to this program, you are worried for not just your patients, but for your own family and for yourself. You don't want to catch the virus because you know that you are at one of the highest risks of catching this disease. And especially if you are above 50, you have problems like diabetes or hypertension, or you take certain drugs, you know that you're probably at a much higher risk of having a bad time than the younger ones or many other ones. So that is the reason why all of us are so keenly watching the COVID scenario change in bewildering ways. I just have a couple of things to say. You know, look at the instrumentation for surgery. Those of you who started laparoscopy a couple of decades back might be familiar with a safety trocar. A trocar which has, like in a Verey's needle, it has a blunt obturator which protects the sharp tip of the trocar the moment it goes past the peritoneum. So it prevents bowel injury. So it was sold as the safest possible entry in laparoscopy. So at that time, my boss, Dr. T. Udvadia, said something which has stuck with me all my life. He said, surgeons make the instrument safe. Instruments don't make the surgeon safe. So PPEs, all these masks, shields, respirators, all of these do not necessarily give you safety, and evidence of experience across the world suggests that the reason why healthcare workers are getting infected in spite of using PPEs is because, one, there is some window where they are careless because they are getting tired, mind is getting burnt, and sometime you touch your face or you just remove your mask and drink a little water, or you go to the toilet, something like that happens and there is a breach in the protection. That is the other, as Ashwin said, the donning and doffing is not followed meticulously, and it is difficult for surgeons to learn at this stage. Many experienced surgeons are already in a habit. Break that habit and get into a new form of regimented, very strictly regimented donning and doffing procedure is extremely frustrating, irritating, and a surgeon may typically cut short, typically how surgeons are. They just want to cut short any excessive waste of time. Now that may be the undoing of a surgeon who is using PPEs. And that is what I'm most afraid of. The other things are outside your control and they're very unfortunate. Like, you are taking due precautions. You are operating on a COVID negative patient, but the cesarean section, which is happening next OT, is a COVID positive patient, and nobody knows and nobody cares because they think it's just a matter of taking the baby out. And other people are not following the standards which you have in your mind implemented very strictly inside your operating room. So these are some of the ways in which you can get hurt, your team can get hurt because somebody else is careless. Fortunately, I don't have an answer to this. Constant education is very tedious. Trying to educate everybody can make you very unpopular because you will see senior surgeons sitting in surgeon's room with another 10 people surrounding him with his mask on his chest, and he's just talking as if he's God. Now, this is very unfortunate. But they believe that they don't have COVID and it's okay for them not to wear a mask. In today's world, it is basic etiquette. Just like you have to put on a trouser before going in front of anybody, you have to put on a mask before you go in front of anybody. That is normal. So fundamentally, I think there is a lot of relearning for all of us to do. And that, I think, is a bigger challenge than merely having masks and other equipment to protect us. We need to protect us from ourselves. We are the biggest threats. Thank you very much.
Excellent.
Thank you very much, sir. Here is our, we have one anesthesiologist here. So, Dr. Jerin Delor Hussain, just shortly, please, about the operation theater safe protocol. Dr. Jerin Delaroche.
Thank you. Assalamu alaikum and good evening. It is a privilege to be amongst all the surgeons, because I'm sure the surgeons cannot do without anesthesiologists. So I feel humbled and privileged to be amongst all the surgeons, where I work in the operation theater. And I've been doing anesthesia since 1990. Professor Ruhul Haq sir, if you remember me, I was in Dhaka Medical College. And Konokanti Bodua sir is also there. Them and all the senior in 1989. So talking about myself, I'm an anesthesiologist, and I went further one step ahead. And I did my fellowship in beating heart surgery from Escorts Heart Institute and Research Center. And I started doing beating heart surgery with Sandeep Atawar in Apollo Hospital. And I worked with him for three good years. Then I was called by Holy Family to lead the ICU. And then I was working as an ICU head over there. And then I was hungry for more knowledge in the field of anesthesia. At that time, palliative medicine was under anesthesia department. So I went to BSSMMU and worked in palliative medicine for 6 good years. So that is my exposure to anesthesia. Now, talking about protection, today I speak in the capacity of an entrepreneur now. Now I am an entrepreneur, a pharmacological entrepreneur. I am a CEO and MD of a pharmaceutical company. So in the modern world, there are 3 types of protection. One is your personal protection, which Dr. Arif and Dr. Bawa had said. After your personal protection, there is another layer, which is called ambient protection, which is making the air around you little purified, lowering your bioburden. And the third protection is the biological protection, that is the medicine and vaccine, which we are waiting up till now. So let's concentrate on personal, which already has been presented by Ashwin Bawa. He looked to me like a scientist. And
Shortly, please, madam.
Since I am also working in this field, so I know a lot of things. So when I go to doctors, to surgeons, I ask them, I see them wearing surgical masks, and I ask them, how did you wear this mask today? And he said, well, I was going out and just put on the mask. I said, no, sir. I've done a certification course in COVID-19. I've done a certification course from London School of Medicine, Tropical Medicine and Hygiene. So first you need to sanitize your hand. And with your sterile hand, you pick up the earpiece and put it behind your ears. With your sanitized finger, you just put it and fit it on to fit it to your nose. Then with the palm, you put it like that and make sure it is fitted properly. So that is the proper way of wearing a mask. So none of us are specialists, but today, because of this, we are learning, every day is learning, but some learnings are epidemics also, which scares people. And when the mind gets scared, what happens? Your good hormones do not secrete, and your bad hormones you go into depression, and your immune system goes down. So I want to say that not only COVID, there are 60 million people who are suffering from so many diseases all over the world. 2 million are dying. So let's protect us. Let's protect us. Nothing will give us protection, 100% protection from COVID-19. Today, my heartfelt condolences to all my fraternity who have served and who have been martyred in this battle of pandemic. And a lot of families who have been, children who have been orphaned by the death of their father or the earning member. So let's be a little realistic. I would like to say that I was working for the last 2 months, how to be a little more protected, go one more step ahead. So I was going through a lot of studies in PubMed and then searching in Google and everything. I found out that in Japan, they have made a a device which helps. It's like a badge, and I would like to show it. I'm wearing it. It's called Air Doctor. It is an innovative technology where it is patented in 2023. And I was looking for, and I was writing them, hey guys, can I get it? I want to protect myself. I want to protect my family. I want to protect my fraternity. And they after a lot of emails, they responded. They said, yes, we are patented. And thankfully, after a lot of, I would say, battle and getting a lot of certificates like ISO, WHO, FDA, and EPA certificate, I finally managed, from DGDA, I finally managed to launch this in Dhaka, in Bangladesh.
Thank you, madam. If you don't mind, we have another panel of experts. So thank you very much.
This is for ambient protection that I'm using. And India has launched it today. Thank you so much for the patient here.
Thank you, Dr. Jerin Delhorasan, for information. Now I would like to Professor Maudud Hussain Alamgir, Professor and Head of the Department of Surgery, TMSS Medical College, Bogura. He is the ex-President of Society of Surgeons of Bangladesh. Professor Maudud Hussain Alamgir, sir.
Thank you very much, everybody. It is an honor, privilege on my part to be here, and I just want to thank to the organizers of this program. I am holding a peculiar position, in fact. Though I'm not a COVID expert, but as the chief of the infection control team of our hospital, we have developed our own infection control protocol, which is a small booklet, which we have produced some 2 years back. If our society is interested, definitely I can just send it to them for just circulating that amongst our members if we feel that it's of any use. And about the hospital, what I can say that our hospital is a 1,000-bedded hospital. Now we are taking care of both COVID and non-COVID patients. Right at this moment, we are having 200 plus patients in our red zone, that is in the COVID area, and rest of the patients are in the non-COVID areas actually. What we are very serious about is that we are just zone-wise, we have divided our hospital into red, green, and yellow zones, and we strictly avoid zone contamination. Strictly avoid zone contamination. No way we allow anybody from the red zone to go into the green zone or vice versa. That is most important thing. I think that is the reason why we could keep all our health workers and whole health were free from COVID so far. We are working for more than 60 days, and none of our doctors and any health worker working in the COVID area has been infected so far. Some of them are infected, but they were in other zones, not in the red or yellow zone. And about the surgeries, what we are doing, we have kept 3 operating theaters dedicated for our hospital. The green for non-COVID and the yellow for the emergency patients who are coming without any proven documents whether he has got the COVID or not. We have our own PCR machine, so we can just send the sample right at that moment for testing, and the proven one are directly going to the red areas. What I just want to emphasize one point is that we are producing our own face shields in our hospital from the indigenous material that we have. We are using a simple laminating machine, you know, that laminating machine, we are just putting 2-3 layers of the plastics, and we're just putting all together and just pressing on a heat pads and just preparing our own, and have sent one small video clips to the president and the secretary of the society. And if they feel that is of any word, then they can circulate amongst the other hospital personnel. One more thing we are using is that we know the trouble of doping. Actually, that's a very difficult thing to teach our health workers. And even if we try to do that under supervision, that was also not of that much of use. So what we could develop, we have provided them with one plastic, one-time use, disposable apron that we just use over the coverall, and that makes things easy because that is the disposable one. And after disposing that apron from, and then the doping become a little bit safer, to our best of our knowledge. That is one thing I just want to mention about. And another thing is that we are strictly on the triage. Everybody coming to our hospital definitely should go to the triage point. With symptoms, go to the red and yellow zone, with no symptom to the green. But they prove it whether he has got any reason to be going to the other zone areas. And we just try to keep these things in such a way that whatever Dr. Arif and Dr. Bawa has said, we are just all trying to practice the same thing that they have said. And overnight, we cannot change all of our theaters into negative pressure. That's not possible. But to best of our ability, we should try to follow the protocols as far as possible. And about the face mask that he has said that it's 5 or 6, we are giving 5 or 6 face masks. About the face mask, Dr. Bawa, one thing I just want to mention, that in our country actually is a N95, it's a little bit questionable. These are all fakes mostly. If not, the 8210 is little bit all right, but as it is not the waterproof, it is very difficult to get the proper 1860. So what we are trying to do, we are using FFP2 actually. That is little not non-popular, and that's why it is a little bit less fake than the rest of the 3M. That's why we are trying to use that. And we strictly avoid all filters, mask with filters.
Absolutely.
We don't allow any filtered mask. So I think with this, I am sure that if we can just stick on this triage protocol, and that is most important thing, we should avoid the zone contamination. Even our elevators are dedicated. Nobody with any red tag on his chest or anybody is using a red card is not allowed to get into the green elevators. So we avoid the zone contamination. That's important. And then lastly, just I want to say that our hospital provider, they are staying in the hospital. They are not allowed to go outside for the quarantine and isolation. So thank you for giving.
Thank you, sir, for information. Now, I would like to request Professor Dr. Tamanoj Chaudhary, ex-president of Association of Minimal Access Surgeons of India. Professor Tamanoj Chaudhary, please, sir. Is Tamanoj sir here?
Yes.
Yes, sir. Yes, sir.
Thank you very much, Dr. Noor and Dr. Mamoon. And I'm very happy to see PowerL sir.
Sir, little bit above, sir.
Okay. Can you see me?
Yes, sir. Yeah. Nicely. Yes, sir.
I'm very happy to see the PowerL sir. PowerL sir, you kept a long beard. You are looking very good, PowerL sir. So basically, you know, this is a challenge in the whole globe, and all of us in this war, Corona war, and we are the warriors. We are in the front line. So we must take all kind of precautions. There is a lot of lectures since IPC, then followed by Dr. Bawa, a lot of things discussed. But at the end of the day, the person who is on the front, he must decide and he must understand that what is the best for his own protection. I know somebody who is a professor of a department and conceal the fact that the patient is not tested for COVID, and he put into the theater and the patient is get operated, and afterwards that report came as a positive. So is it a real responsible professor? We must think of it. So as if we are not responsible, nobody can make it. I am very sorry to say, almost in Bangladesh, we lost 70 doctors in COVID. It is very unfortunate. To create one doctor and an experienced person, it takes a lot of time, lot of energy, lot of things. So we cannot lose one healthcare workers and a doctor. So friends, my one-line suggestions, and that is from Chanakya. If you cannot see the enemy, it is your job, you should also go into the oblivion. Means you should not be visible. If you cannot see your enemy, you should be invisible. And that is the PPE. How we can make ourselves invisible? By putting PPE and all kind of protective gears. Because we cannot see the enemy. And in this war where we cannot see the enemy, we should be invisible. So friends, there is a lot of things we have to start. We have to live with this era of COVID and Corona. We have to take all precautions. We have to operate. I'll not talk anything very specific technology. There is a lot of things available now, how to protect ourselves. My only suggestions, please take precautions. Don't compromise anything rather than personal protections. And if you take personal protections, that is a protection to the society. It is not that you are selfish. It is not a question of selfishness. It is a personal protection for social protection. The new normal era is take personal care for the social care. And if we don't take personal care, we cannot take care of the society. That is the message for all my friends. Thank you very much once again to all my friends of Bangladesh surgeons. I feel আমি সবসময় ভাবি যে আমি আমার বাড়িতে আছি, আমি সবার সাথে কথা বলে আমার মনে হয় আমি যদি বাঁচি তাহলে আমার দেশ বাঁচবে, আমি যদি বাঁচি তাহলে আমার দেশকে আমি সেবা করতে পারবো। আর আমি যদি মনে করি যে আমার আত্মত্যাগে দেশ উদ্বুদ্ধ হবে, সে একটা সময় ছিল যখন আমার আত্মত্যাগে দেশ উদ্বুদ্ধ হতে পারতো। এখানে আমার আত্মত্যাগ হচ্ছে আমি কাজটা করব, আর আমার প্রোটেকশন হচ্ছে প্রোটেক্টিভ গিয়ার্স। আমি যদি প্রোটেকশন না নিয়ে মনে করি আমি আত্মত্যাগ করছি, তাহলে আমি দেশের ক্ষতি করছি। এটাই আমার মনে হয়। এইটুকুই আমার বলার কথা। সবাইকে ধন্যবাদ জানিয়ে আমার কথা শেষ করছি।
থ্যাংক ইউ ভেরি মাচ। অনেক সুন্দর সুন্দর কথা বলেছেন। আসলে আত্মত্যাগ করে কোনো কিছু এখন উপার্জন করার মতো সময় নাই। এখন নিচে গিয়ে প্রোটেক্ট করে এগোতে হবে এবং প্রোটেক্ট করে সমাজকে এগিয়ে নিয়ে যেতে হবে। ধন্যবাদ স্যার, থ্যাংক ইউ ভেরি মাচ। নাও আই উড লাইক টু রিকোয়েস্ট প্রফেসর মোহাম্মদ জুলফিকার রহমান খান। হি ইজ এক্স প্রেসিডেন্ট সোসাইটি অফ সার্জনস অফ বাংলাদেশ and chairman of Department of Hepatobiliary Surgery, BS Bangladesh, Bangabandhu Sheikh Mujib Medical University. প্রফেসর মোহাম্মদ জুলফিকার রহমান খান।
আমি ফিরে এসেছি তোমাদের মাঝে।
স্যার থ্যাংক ইউ স্যার।
থ্যাংক ইউ
স্যার। আমরা যে আমাদের ফরেন ফ্যাকাল্টি সহ সবাই আমাদের প্রায় সবাই বক্তব্য দিয়েছেন এবং
আমি কিছু কিছু শুনেছি, সবটা শুনতে পারিনি, কিছু কিছু শুনেছি।
There is a very good presentation from Ashbin Bawa and
ওনাটা প্রায় সবটাই দেখেছি।
Yes sir, yes sir. So I request Professor Zulfikar Rahman Khan. Zulfikar sir. Is here Zulfikar sir here?
জুলফিকার হারিয়ে গেছে।
এই শাহিন তুমি আর কাউকে বলো।
নেক্সট ম্যান
আমাদের মোটামুটি শেষ হয়ে গেছে। আমাদের এখন স্পেশাল গেস্ট বলবে
রুহুল হক স্যার যেহেতু ফিরে আসছে, রুহুল হক স্যারকে বলবে কিনা
স্যার একটু পরে। তাহলে আমরা এখন তাহলে কনক স্যার আছে। জি স্যার, I would like to request Professor Konok Kanti Borua, the special guest and Vice Chancellor BSMMU. Professor Konok Kanti Borua sir.
The line online.
Professor Konok Kanti Borua. Konok sir.
Not bad.
তার না থাকলে আর কারো কাছে যাও, সময় নষ্ট করো না, সময় চলে যাবে।
কোন স্যার তো স্ক্রিনে দেখা যাচ্ছে না তো স্যারকে।
আমাদের প্রায় শেষ স্যার।
তাহলে পরে শেষ করে দাও।
আমার মনে হয় আমরা প্রায় শেষ। কনক স্যারকেও দেখা যাচ্ছে না। তো স্যার একটা ফোন করেন, তারপর আমরা এর মধ্যে আমরা একটু এটা করি। আমরা যে আমাদের আমি সোসাইটি অফ সার্জনস অফ বাংলাদেশের পক্ষ থেকে many thanks to Dr. Ashbin Bawa and Dr. Arif Hussain Khan. Actually really there is a very beautiful presentation. They cover the all aspect, and also thanks to the Professor Maudud Hussain Alamgir, Professor ABM Khurshid Alam, Professor Tamannash Chowdhury, Dr. B. Ramana, and all the faculties, senior faculties here, also Khadam sir, including all the senior faculties here. I give many thanks to all the senior faculties. If here is not the Konok sir and the Zulfikar sir, so again
Konok sir is not responding in his phone.
So again I request Professor AFM Rulok sir, please. Professor AFM Rulok, he was the successful health minister, Ministry of Health and Family Welfare. Actually, sir, we continue our.
Can you hear
webinar.
me?
Yes,
Dr.
sir.
Shahin, can you hear me?
Yes, sir. Yes, sir. Khadam, sir. Any comments, sir,
Can I
please?
have a few words?
Yes, sir. Yes, sir. Khadan, sir.
Okay, thank you, Dr. Shaheen. I would first congratulate all the speakers of today's webinar for their nice presentation, and particularly very important message from Professor Tamanish Chaudhary and other speakers, that it's we must have to be very careful to protect ourselves, and our protection is important for the protection of the family, for the protection of the society. So we must have to be very careful about the use of the protective gears. That is important. It's not the protective gear that can give us the protection, but how we are using it, how we are practicing it, that is very important. And already our Professor PowerL nicely mentioned that how a hospital should now function. Clearly, the red zone, yellow zone, green zone, a triage area, the screening of the patient into COVID, non-COVID, and suspect, and accordingly we should prepare ourselves to serve the patient. If I handle a non-COVID patient, definitely I don't need to go for strictly following all the protective measures. But definitely, when I am doing some surgical procedure in a patient who is unknown status about COVID or COVID positive, then we must have to follow strictly all the infection control measures and the protective gears. So with these few words, I like to thank all the participants, all these today's learned speakers, and this definitely will create awareness among ourselves. Thank you very much.
Sir, thank you, sir. Thank you very much for sharing the information. Maybe here now the Zulfikar sir joined. He again and again disconnect. That's why he cannot connect with us. So if Zulfikar sir connect here, so I would like to.
Yes, he is in the screen. He is in the screen. Yes, yes.
So Professor Zulfikar Rahman Khan, sir.
Thank you very much, Dr. Shaheen.
Yes, sir. Sir.
Mr. Chairman of the session, the President of Society of Surgeons of Bangladesh, the Chief Guest, our Honorable MP, Professor F.M. Buflohak, past Minister of Health and Social Welfare, Government of Bangladesh, and our very beloved teacher, and our Vice Chancellor, special guest, my senior colleagues and members of Society of Surgeons of Bangladesh, and non-foreign speakers. Good evening. Actually, this is a great pleasure for me and great privilege for me to speak some few words. Actually, all presentations I enjoyed, but in the situation in Bangladesh, I like to highlight some points that we surgeons, we are sitting in the room for last 5 months, 4 months, so it's almost 4 months. So actually, thing is that our hospitals, we are working in both in government sector and private sector, are not well prepared to accommodate us. So I will request our hospital authorities, both in the government sectors and private sectors, to prepare the operation theater and to create the environment of the hospitals so that we can work there. So some of the surgeons are working in the hospital, but I think that they are not working properly with all precautions which we should take, as Dr. Bauer told us that we must have very good precautions to get the environment to do the surgeries. Like I can give you an example that the operation theaters are not that much standard one. Then the mask only the mask is not. We are not getting the ideal mask with which will fit very well with our face. We don't have that mask. So if our authority is asking that why we are not going for surgery, if we don't get the mask, only the mask, how can we go for surgery? And there is a chance of infection for the surgeons as well, the whole OT staffs. So if you provide one mask to N95 standard mask to surgeons only, and if you don't give that type of mask to the other staffs, it's useless because everybody will be affected. So, and there's so many examples in our country. So in many hospitals, like I came to know from Dhaka Medical College that many of the surgeons are infected when they have got when they have done the operations on emergency cases even. So we should think in that way that the hospital for the government sector and the private sector, they should prepare. So I'm doing, I can give example of our government hospital, that the hospital I'm working, the whole building has been converted to a COVID unit. So our main operation theaters are in that building. So all operation theaters are closed. So we will have to do very limited operation in only 1 or 2 or 3 operations in the main building. I'm talking about the PSMM. And the private hospital like that, I used to do private practice in Levy. The whole hospital converted to COVID hospital. So I cannot go to the hospital because there's no preparation for the non-COVID patients. So in this way, actually, in a situation of our country is still in a learning stage. So we are trying to prevent the infection. We are trying to save the COVID patient, but we are not looking into the management of the non-COVID patients. So I will request all the authorities that we should come forward to create an environment. Talk about that doctors should create the environment. So how can I create an environment? You will have to provide the service system, then I can work there. So that is my view. And I've got a question to Mr. Bawa, that he told that the mask. Are you here, Mr. Bawa? Anyway.
Yes, sir. Yes, sir. Yes, I'm here.
So with these few words, I want to finish, but
Yes,
I like to
here,
thank
sir.
all the speakers that
Dr.
fantastic, and I have
Bawa,
learned many things from them. and I like to thank our chief guest, that Professor Ul Haq. He has given a lot of time to us. And I like to thank our special guest, Professor Kanakanta Garua, and our very senior teacher, Professor Majid, and Professor Khadimul Islam is also here. So with a few words, I like to again. Thank you very much, everybody.
Thank you, sir. Thank you, Professor.
Julfikar sir, Dr. Bawa in that line. You can ask your question, sir.
Mr. Bawa, just I could not follow you. That you talk about the N95 mask,
Yes, sir.
about the reuse.
Yes, sir.
If we use once, then we will not go for wash or we will not go for disinfect with the chemicals. So we'll just keep those things for 5 days.
Yes, sir. So yes, what happens is once you leave a mask like that in a brown envelope where air also enters, it causes these viral particles and everything to decontaminate on its own. They become deactivated after 5 days, sir. So
Okay, thank you very much. Thank you very much.
Not following anything, so just by leaving them like that, you can decontaminate them.
Okay, thank you very much.
Yes.
Dr. I have a simple question to you.
Yes, sir.
Can you hear me?
Yes, sir. Yes, sir. Absolutely.
Yeah. My question is, I am Professor Khadimul Islam, retired professor of surgery, practicing in Labid Hospital, Dhaka. Of course,
yes,
for last 1 month, I am off from my practice because of the increasing incidence of the COVID patient in our country. And as Professor Zulfikar Rahman already mentioned, that our hospitals are not yet organized, functional organization in that way, that COVID,
yes,
non-COVID, the intermediate zone. But we are trying to make the things separate. But my simple question is that you have nicely described the different protective gears, the advantage, disadvantage, the usability, use, etc. But when I am going to operate an screened patient who is COVID negative, And
Okay.
the operation theater is also a dedicated non-COVID for patients. Do I need to go for this all infection control measures and use of the gadgets for the what should I use for the COVID patient?
Okay.
I operate in a non-COVID patient.
Sir,
In the non-COVID patient.
Trying to, sir, I will start from the background. We are a 1600 bedded hospital, and the cases in our town are increasing. We are like 40 lakh people in our town, and we get about 60 positives and about 10 to 15 turn positive every day in our hospital. We are screening all admitted patients in our hospital with an RT-PCR test, which we have in-house. So most of our surgical patients operate on acute gallbladders. I have special interest in diabetic foot, and other patients are usually screened. But please remember to follow all precautions, absolutely all precautions, a proper N95 mask and all precautions, because sometimes your patient can still test positive in the post-op period. We have had instances where patients, for example, a patient with gallstone pancreatitis who was tested negative at admission, tested positive after 10 days, developed fever and cough, and then a repeat COVID test was done, and then that patient turned positive. So we have had problems in our hospital where these patients have tested positive, and a lot of our healthcare workers, sisters who were taking care of a patient very, very casually, not wearing a face shield, not wearing an N95 mask, and attending to 2-3 patients together in the surgical ICU also tested positive later on. So we have had our own share of outbreaks. So I recommend wearing all possible gear at all times, taking all precautions, so none of your surgical team or anybody else becomes positive at any point. So any COVID negative also can be an asymptomatic carrier, may test negative as well, despite an RT-PCR, might test positive, might infect you. So please take all possible precautions.
Thank you, Bawa, for actually clear clarification. Now I would like to request Professor A.F.M. Rulok sir again. Sir, say a few words about.
And so just a little word on. We don't have negative pressure OTs here as well. We have normal OTs, but I think so we are following all possible precautions and taking all precautions, and it is keeping us safe till now. For laparoscopy, even we are not using any smoke evacuator. We are just using hypochlorite in a bottle, like a chest tube bag with air seal that is taking care, and we still are safe and doing okay.
Thank you very much. Now, Professor A.F.M. Rulok sir, sir is here.
I'm here. Yes.
Sir.
Am I allowed to ask a question to Professor Bawa?
Yes, sir. Definitely,
sir. Sorry, before starting, just wanted to know, Professor Bawa, that the N95 mask, how many times if you reuse, is there a time limit in days or times that one can use 5 times, 10 times, or whatever? Is there?
Sir, I covered that in my presentation as well. I think so. The permissible limit is about five times you can reuse, and it should be kept in a brown packet. I showed a slide where we number them, and so that the one that the days you can use comes out to be 4 or 5. I ideally use them for only 4 times, sir. So 5 masks over 4 times makes it 20 days, sir.
Thank you. Sorry, I missed part of it. Thank you, Professor Bawa, and all the team from India and other places. It's a wonderful session by the Society of Surgeons. We have been doing this for quite some time. I see a lot of senior people. I see the cardiac surgeon coming, and Professor Jahangir, thank you very much. I see my good friend, Professor Mazid, Professor Kadem, and all the seniors that have come here to talk. And I think it's a wonderful session. Thank you very much. Thank you. After a long time, I've seen Dr. Kadem. What is been worrying me for a long time that everybody has mentioned that a lot of doctors and paramedics in our country is being affected. And what I saw part of the Professor Bawa's presentation, I couldn't see because I had to go for a national television talk show at 9 o'clock, so I had to leave. So there are many other things other than downing and doping, and many issues that has to be considered why the people get infected. And the presentation by our good friend from Arif about the infection control business. I think that is a very important issue. I hope that our senior teachers here take issue on this and to prepare our hospitals to be like this. I know many of them, as I said in the beginning, most of the hospitals are not built and don't have to separate entries and etc. So we have to take care of this side. The infection control team is the most powerful team. I talk to the Chinese people, I talk to the American people, I talk to British people, and this is one of the most important things that we are missing in our country, and that should be taken care of. So I think we always learn something through the special problems. So through our problems, we are learning many new things. Our surgical team and surgeons, so what Khadem was saying, I totally agreed with Professor Bawa that even if you say if you are going to operate on a patient who is COVID negative, I think we should be fully prepared and protected, because a lot of these patients are unsymptomatic and a lot of the patients are COVID negative that comes into their PCR machine, becomes positive and gives a false result. So these are very important issues and should be taken very seriously. I was listening to the presentation of our Bogura team, and it's wonderful. I would love to come and see and how they are implementing it. I hope that this Society of Surgeons take an issue of this publication and the booklet and can implement it some other places. So that would be a wonderful thing. Our infection control is the issue, and if we could control this, then that would be wonderful. What I heard from him, that he has been able to protect all the health workers in his hospital, I would like to congratulate on that. If that is true, if that's what I heard is true. It's a very wonderful situation. Thank you very much. I think you should come and train all our doctors in the country. That should be the way that should be taken care of. Our COVID has been teaching all the doctors and the people all over the country so many things, and part of this thing is infection control, which is very important to all of us. As surgeons, we have been looking into this for since our training time, and hopefully this time we have learned little more than before. I hope to learn little more once I become a part of this discussion anytime coming in future. I would like to thank everybody, especially the Physical Society, to bring me in. For my friends from India who doesn't know me, I'm an orthopedic surgeon trained in UK. I was a professor of orthopedic surgery before I became politician, and all these friends that know me very well. So basically, I'm an orthopedic surgeon and still practicing orthopedic surgery. So I would like to thank all our fellow friends in Society of Surgeons. Please do take care, stay safe, and try to make your colleagues safer than before. Best wishes from me to take care. Assalamu alaikum.
Thank you, sir. Thank you, Professor AFM Rulok MP, former health minister. He's a renowned orthopedic surgeons of Bangladesh. Now we at the end of the session, I'd like to request Professor Tauhidul Alam sir, AHM Tauhidul Alam, President Society of Surgeons of Bangladesh, to conclude the session. Professor Tauhidul Alam.
Good evening, everybody. First of all, I'd like to thank our chief guest, Professor AFM Ruhulok sir. After a long time, we got him in our webinar. We are really happy. And Professor Konokanti Bodo, who is another special guest, I think sir is busy with some other important issue, so he has left the webinar. And we have got we have got few senior teachers of our country, Professor Emi Mojid sir and Professor Khadam Islam sir and other senior surgeons are there. I thank everybody for joining this webinar. And first of all, I'd like to thank the two presenters, Dr. Arif Salam, Dr. Arif Hussain. He has mentioned very basic thing regarding surgery, because all the surgeons, we are now busy with the laparoscopic surgery, robotic surgery, whatnot. Every advanced, we are busy with advanced surgery. But what you have seen the last 3-4 months, we stuck in a very basic thing. We have just simply unknown, unseen virus. They have paralyzed the whole world. So we are remodeling, or we are thinking our surgery in a different way. Another way, I like to thank other few speakers from abroad, Jerin Hossain, Dr. Ramanna, Dr. Tomonesh, and Abhijit Bawa for their presence in this webinar. My special thank to Dr. Bawa because he has presented very nicely the basic things in the protecting air in our this COVID era. Because what we have seen for the last 3 months, we have lost 72 doctors from our country. So everybody is aware of this protective gear and PPE. Everybody is wearing, but I think there is some breach in the protection. There is some lapse is there where we cannot follow this protective measure regularly. And another speaker, he has nicely mentioned we have got very little control outside our environment. Say for example, we are those who cannot drive. We are bringing our driver with us, and our home is not protected. The mates are coming daily out from outside inside to our home. There are certain area where we cannot block completely. So there is some area, there is some breach in our protective measures. And another thing is that in our country, all hospitals are not designed like this. As Professor Maududin Alamgir has mentioned, in his hospital, he has divided his hospital in 3 zones: red, green, yellow. But as you see, most of the government hospital, you cannot divide this hospital in 3 zones. So it is very difficult to contain this infection in a particular zone. So this may be another region. What we have seen in the this Italian experience. What we have seen in the Italy, their casualty was more in the initial phase because they could not separate the hospital in different zones. That is their experience they are now sharing. So this is another point. So the main thing is that we have to protect ourselves, we have to protect our colleagues, and we have to protect our family, and finally we have to protect our patients. And with this motto, I think we will take care of ourselves definitely. And last of all, I would like to put one request to our chief guest, Professor Ruhul Haq, because we got our sir after a long time, because he's in a policy maker. So, sir, you have seen in this COVID era, our doctors are humiliated in different area. Even one of doctor died of some incidents, as you know very well. So, my request to sir, we have got many doctors, MPs in the parliament. So, please, sir, you should put forward our the surgeons protection or doctors protection law or patient protection law that was designed very in 1914, I think. But it is not yet finalized. So my earnest request to sir and other members of the parliament, those who are doctors, to put forward these laws and to make it as a so that we can protect our doctors, or doctors can be protected, particularly in this odd situation. With these few words, I like to thank everybody. There are few surgeons, there are few senior surgeons in this webinar also. I have seen the president of the secretary of the American Society of Surgeons, Dr. There is Professor Muzammil, Professor Syed, Professor Ayub Ali, Sadat Hussain Sheikh, and lots of senior professors, the Naim, few of the senior professors was in the webinar. I thank everybody. With these few words, I would like to conclude this session, and stay safe, and let's pray for all those who are demised in this COVID war. And we pray all those doctors and all patients who are suffering in COVID. With these few words, thank you everybody, and we conclude this session. Thank you.
Thank you, sir.
Thank you.
Thank you very much. Thank you.
Sir, Rulok, sir, thank you, sir.
Thank you very much. Thank you.
Thank you, sir.
আমাদের ডাক্তারদের প্রোটেকশন জন্য স্যার কিছু একটা করেন স্যার। আমরা এখন আমাদের ফর্মাল সেশন শেষ, আমরা ইনফরমালি কথা বলি যদি কেউ কিছু বলতে চায়। যেহেতু স্যারকে পেলাম অনেকদিন পরে, স্যার আপনি ল মেকার, আপনি যেহেতু একজন স্যার আমাদের ডাক্তারদের
স্যার কোরবানি সম্বন্ধে কিছু বলেন স্যার। কোরবানি